last week saw two major medical breakthroughs. The first of which was the World Health Organization's endorsement of a vaccine shown to prevent one of the oldest known and deadliest parasitic diseases in the world, malaria. The approval follows the successful pilot immunization program carried out in Ghana, Kenya, and Malawi. Director General of the World Health Organization, Tedros Ghebreyesus, describes the vaccine as a breakthrough for science, child health, and malaria control that could save tens of thousands of young lives each year. He says the vaccine could be rolled out across sub-Saharan Africa and in other regions with moderate to high malaria transmission.
Malaria has been with us for millennia, and the dream of a malaria vaccine has been a long-held but unattainable dream. Today, the RTSS malaria vaccine, more than 30 years in the making, changes the course of public health history. We still have a very long road to travel, but this is a long stride down that road. This vaccine is a gift to the world, but its value will be felt most in Africa because that's where the burden of malaria is greatest.
Well, joining me now to discuss this is Professor Olumuyiwa Odusanya. Professor Odusanya is a professor of public health at the Lagos State University College of Medicine. Good to have you on the show, Professor Odusanya. Thank you for joining us.
Thank you very much, sir. Ruben, I'm glad to be here.
Yeah, but Prof, okay, quickly. How much of a breakthrough, how historic, is the malaria vaccine that we're now talking about? Is it truly something to jubilate about? And how much of a breakthrough is the treatment for sickle cell, which we're told will reduce hospitalizations and help to prolong lives?
All right, thank you. Let's start with the malaria vaccine. Like the Director General of WHO did state, this vaccine has been relevant for 30 years. So it's not as if something came out of the blues yesterday. There have been several studies in several African countries, at least 13, from about 2004 to about 2014. And in 2015, a landmark paper was published. It also received approval, positive opinion from the European Medicines Agency. In fact, as far back as 2010, there was a global advisory board on which I sat looking at that vaccine. And so it's been long in coming. When all the information that was a good vaccine with about 30 to 40% vaccine efficacy, that means that if you give it to people who have, it will prevent 30 to 40 of them from having malaria, which is a very good mark for this difficult disease. Then WHO felt we should then do a pilot test in where the great risk was greatest, and 3 countries, Ghana, Kenya, and Malawi. And we have used in about 800,000 children, and results have shown its efficacy and its safety. So it's a game changer in that with this vaccine now given along with the routine vaccination program at 5, 6, 7 months, not less than 9 months, and a booster dose at 18 months, the burden of malaria will substantially reduce. Let's remember that about over 200,000 children die in Africa from malaria, over 50% of the bodies in Africa, and nothing has really worked to prevent it. This will give us a quick public health tool, a layered tool to add with a central treatedness with environmental control. So it's a very, and this is the first time WHO is saying this vaccine can work. There was an older vaccine, bacterial vaccine, that failed a clinical field test, but this has worked, and it has worked very well.
Well, Prof, okay, maybe we'll get to sickle cell later, but this malaria vaccine, you pointed out that there was trial in Ghana, Malawi, and Kenya. Some reports also mention Burkina Faso. Why is it that, when these pilot programs are brought to Africa, Nigeria is never there. How come, the Nigerians that have been involved in this are Nigerians in diaspora? Is that a reflection of the status of the public health and research and development infrastructure in Nigeria?
Oh, certainly not. Because indeed, the initial studies included Nigeria, and malaria studies have been done by the late Professor Salakwa and his group worker at USAID. And I have also done some malaria studies with Alofantrin, surface of Nigeria. So even the initial set of studies, but this was the large-scale pilot study. It can't be everywhere, where you wanted to pull as many children in a single or few countries so that you can closely monitor them. Nigeria has its own data for the Atres vaccine. It was so many years ago before we got to this pilot stage of field use. So there are two separate things. The initial clinical trials, Nigeria was involved because these were company-sponsored studies, but the WHO program chose only 3 countries. Yes, and there are reasons because they have a far better organized immunization routine programs. They've had more successes, more records than Nigeria, and so that's why they were choosing. But it's a win-win for everybody on the African continent. And so it's not that Nigeria is doing badly, although these countries, particularly Ghana, has had very fantastic immunization program records that the world reckons with.
Well, but what would be the very clear and specific advantages of this particular vaccine, considering that the P. falciparum, as it is called, is a very deadly parasite? What's going to change?
Well, what is going to change is that this vaccine uses an antigen from the Plasmodium falciparum, which is the most deadly of the 5 Plasmodium species that affect man. So we've taken an antigen, the circumcised sporozoid from the Plasmodium, and we have now been able to use it in children. Their bodies can now mount immune response. One of the greatest challenges with Plasmodium is that it has many changes in the body, but this is one specific one that this vaccine contains and is able to mount immune response to defeat the clinical malaria and reduce the risk of severe malaria in children that have been immunized. So that's the key. Is in immunization, you take an antigen, a part of the parasite or disease, and give it to the body. The body makes antibodies that then prevents the body from falling ill. So that's the game changer in this, that we're tackling the greatest cause of malaria morbidity and mortality, Plasmodium falciparum.
Well, Prof, this particular vaccine with regard to malaria is called Mosquirix. I hope I got it right. But one major concern for many Africans will be costs. Is there any plan in place that you are aware of to engage the international manufacturers of that vaccine to make sure that it is readily available and there will be no questions of equity and justice, those big issues that we talk about with regard to COVID-19 pandemic?
Well, the vaccine development was from GSK and the U.S. Water Aid Army. The Bill and Melinda Gates Foundations, as of example, put a lot of money into GSK has put in almost $700 million, and they're about to even transfer the technology agreement for vaccine to another company. Initial costs are looking at about $5 per dose, but I'm sure when more people come into the basket of funding, like Gavi, the cost will be, it's not going to be a vaccine for making money like COVID. It's going to be a vaccine truly for the needy and at almost a cost that most countries can afford.
Okay, Prof, let's talk about the sickle cell treatment, the drug called crizanlizumab, which the NHS is now going to start applying and which has been approved even by the WHO, and which we're told will reduce hospitalization in the next 3 years, with regard to sickle cell, which is a health condition that we've been told has no cure. How much hope would that bring to persons living with sickle cell anemia?
Thank you. Again, Nigeria has the highest sickle cell rate in the world. That's because about 1 in 4 Nigerians have the sickle cell trait. And so when they marry, we have about 150,000 births of children who are born with sickle cell hemoglobin gene in Nigeria. However, the new drug is not totally new. It's been approved in the US 2 years ago. I think what is making news is that the NHS in the UK is approving and putting it on its list. There have been other drugs, but this has an advantage in that it targets the causes, it focuses on the target problem in sickle cell, preventing the cells from clumping together and sickling and causing pain, and not the problem with sickle cell. So it's a good drug. Like I said, it's been available in the US for 2 years, but it's a drug to be given IV, and the efficacy is about 45% that will reduce vaso-occlusive crisis very well. But the cost is huge. The cost is huge. But it's a very good drug, and it's to be given IV, first 2 doses, 2 weeks apart, and over 30 minutes, and then every 4 weeks. So it will reduce the cost of pain, the cost of having blood transfusions, cost of hospitalization, but it's a long way to get to Nigeria, and the cost is huge.
Yeah, but Nigeria, again, is not part of this research, although there was a lady we interviewed on another program on this station a few days ago who was part of that research and who works with NHS, which takes me back to my point about research and development in Nigeria and the concerns of the pharmaceutical industry in Nigeria. People say routinely that once upon a time in this country, we used to have breakthrough research, even with regard to sickle cell. There was something about Uniata, by, I don't immediately remember the name of the Professor Emeritus. Why is it that all of a sudden we're no longer having breakthrough research in Nigeria? What can we do about that?
It's a multifactorial issue. One, the economy dwindled, the investment climate became very bad, and R&D is big business. But nobody's going to give you money and you give them negative returns. Everybody wants return on investment. Somebody is paying. And so manpower left, strikes have been on, government has not been very sensitive, and so capacity has dwindled, equipment is not as available, power issues, and then so it became easier to be a net importer of drugs. And once you become a consumer of medicines, you cannot do a lot of far-fetched research. It's the same problem we have, even with COVID-19. Other countries are participated in vaccine development. Nigeria has not been able to. Where are the vaccine labs? Where are the places to isolate the virus? Where are the places to have modern day equipment in the country, even to pay for patients, insurance? The manpower is not lacking as much. It's the enabling environment, and we have just kept going down despite, and what we're doing is to proliferate universities, and we're not investing in the laboratory, in the science that make our universities world-class universities. That's a big problem across the board for government, for those universities, and the industry. And industry will not pick the bill if there is no assurance that it will come out well. And there are issues about copyright rules and patent protections. I think we're just beginning to deal with some of those things now, but the train has left us long ago. So that's the reason why we're very little risk R&D in the country.
Well, Prof, when this issue came up about the treatment for sickle cell and the arrival of, you say it's not new, crizanlizumab, which is the treatment that has been announced. The chairman, the board of Arise Television and the This Day Arise Media Group, said, our media organization will provide support for promoting that particular drug in Nigeria to help vulnerable persons who are living with sickle cell anemia. But another issue, beyond private sector support, is that once upon a time in this country, there was a proposal at the level of the national legislature that there should be a bill which would probably compel people to avoid sickle cell, because we're told that it is preventable. If you know that your genotype is of a particular kind, then you don't go and marry somebody of the same genotype. Now, that bill, has not moved anywhere. Don't you think that beyond drug treatment, a lot needs to be done in terms of investing in public education, public enlightenment, particularly with regard to public health issues that are endemic in Nigeria and elsewhere?
Thank you. Sickle Cell Foundation has done a lot. That bill died prematurely. I don't know why, and it's not been resurrected. Dr. Kinshete, who leads that foundation, is somebody well known to me. She's a community physician like myself. There's a lot we're doing, but education is key. Advocacy is key. Raising awareness is key. But even when we pass that bill, it cannot already affect those that are basically already have the sickle cell gene. What we must do is that as early in life, every new child, you have genotype determined. That way, it becomes like a passport. It's not at the point of falling in love or marriage that you can then go and either cook up a genotype or lie to the spouse or to the dating partner that your genotype is this. That is where to begin from. Prevention is always better and faster and cheaper than cure. So we must continue to raise public health awareness on basic health problems that confront this country, including sickle cell. And there's a lot of good work by people in hematology, particularly in pediatrics, in sickle cell. There's a consortium of many universities in this area in Nigeria, and I'm aware of the good work they're doing.
Well, Prof, just before we draw the curtain on this, you're a professor also of community health, and there's a major community health issue, the COVID-19 crisis in Nigeria. What's your assessment of how Nigeria has managed the COVID-19 pandemic so far, both at the national level and at the subnational level?
Thank you. Really, I'm actually going to be speaking about that at the NMA meeting this week. Well, it's a mixed bag. Initially, confusion, denial by some states, Kogi, Cross River, but the Personal Task Force and now Steering Committee and NCDC has done a lot. But I think where we missed it was we tried to medicalize the disease. And so many people still don't believe COVID-19 exists because it was like everybody was going to die, and they've not seen people dying, only a small number, and it's only the deaths of the big men, the rich, that is announcing. So to the other person, it could be malaria, it could be anything. We've not handled that well. And then we're a country that has been begging for vaccines. Most countries put money into vaccine development, advanced commitments. Nigeria did not do that. So on vaccine score, we're doing very little, and we're getting it wrong again with vaccines. We're asking people, if you're going to vaccinate, you can't go to this, but the vaccines are not there. I'm not sure Nigeria has gotten up to 15 million doses of vaccine. Yeah, people are not coming to get vaccinated, but until it is available in large quantity, we cannot be telling people if you don't get vaccine, you can't go to church, you can't go to cinema, you can't go to this, you can't go to that. So it's a mixed bag. WHO recognizes the efforts we have done pretty well, but in a number of states, it's not been very well done. It's been fire brigade approach, but I think maybe about just average performance at federal level in many states they've not done as well. The testing capacity is still pretty low. We've just tested less than 4 million samples in Nigeria. For a population of 200 people, 200 million people, that's too small. So in terms of having capacity, yes, but in terms of what we're doing, we can certainly do better. So mixed bag, well, good activities at the federal level. Lagos State stands as a good example, but in other places, they've not done as well. Local governments are actually sleeping when it comes to COVID-19.
Well, thank you very much, Professor Olumuyiwa Odusanya, for joining us on this, the Live the Sunday talk show. We thank you very much for your time
Thank you.
And your contribution.